me. So the objectives of today's talk are to understand the concept of unconscious bias and that we all have it. And it's really important that we pay attention to it and quash it when we can experience it in ourselves. It's important that we are familiar with the terms that are used: macroaggression, microaggression, what is allyship, understand the concept of imposter syndrome, which we'll talk about a bit, which is the feeling that you've somehow gotten there by accident and you don't really belong at a leadership position that you're in. We have to understand why this is important. It's not just important to be nice people, but in fact, there are very specific advantages to overcoming unconscious bias and to creating a more diverse and welcoming workplace. I want to put a plug in as consulting editor of Otolaryngology Clinics of North America. We actually just released the podcast of the special section on COVID-19 and otolaryngology that is published in the December 2020 issue, which is all about robotics. And all those articles are actually free, and the podcasts are all free. So if you go to oto.theclinics.com, you can find them. Another special section that produces 2 articles per issue is a special section on deliberately shaping the future of otolaryngology, and that's being edited by Jennifer Vilwalk from the University of Kansas. I highly recommend these articles. They will really open your eyes and hopefully cement your understanding. The special section on COVID was guest edited by Dr. Zara Patel of Stanford. And then we want to acquire techniques that minimize implicit bias in ourselves and act deliberately when you see it or hear about it occurring around you. So unconscious bias or implicit bias is a prejudice or unsupported judgment in favor of or against one thing, person, or group as compared to another in a way that is considered unfair. So there's explicit bias and implicit bias, and unconscious bias is really implicit bias. So explicit bias is actually less common, and it's essentially racism or some ism against a large group that is overtly said. And because it's so obvious, it's actually easier to deal with than implicit or unconscious bias, which is really an unconsciously held series of beliefs. It is unfortunately widely prevalent, and because it is almost invisible except to the people who are hurt by it, it can be very difficult to mitigate, and it's very important to mitigate it. So if you look at this sort of distinction between explicit and implicit bias, an example to the general public would be a sign in the window saying we only rent or sell to white people. An implicit bias is you don't have such a sign, but it turns out that you different levels of background checks on people who are not white who are trying to rent that apartment. So that's sort of the difference, because if I see a building that says whites only, I can do something about that concretely. It's much harder to determine that the landlord has been discriminating against a certain group when the signs are not that visible. So what about in our world? The quotes that you're going to hear from me are quotes that either have been said to me or said about me or said to or about my friends. Then when we look, silly things that are silly but awful that have been said to me are things like this. We already picked the girl, or we already picked the person of color. I was actually told that twice during residency interviews. And then it took me another 20 years before I realized that I was actually applying not for one of 4 spots, but the one of the 4 spots that they had arbitrarily allocated to somebody other than the white male. My friend, who I do medical missions with in Nicaragua, was told that you can only be a trainee here if you sign this piece of paper that you will not get married or have children. So she signed the paper and she got married and she had children. The implicit biases are you're the only woman, the only person of color, the only person different in the group, and the other people think, oh, she's only here to fill a quota. Oh, I'm sure he's not as smart as the rest of us. They just needed to put a person like him in here. And then the other implicit bias that happens, and this happened actually at Georgetown University for the undergraduate program, when the percentage of women undergraduate students was over 60%, it became known, not Georgetown, George Washington University, it became known as a female program or a female university. And it got some negative publicity among applicants as someplace which was less than. So snap judgments are forms of implicit bias. So you see somebody, the first reaction that happens 95% of the time is this automatic reaction that has no bearing in reality, but does in fact have a lot of bearing in the biases that you embody. The second system is the thinking system, and that's a smaller portion, but obviously much more important portion. So if you have a snap judgment and a direct response that's negative, it's very worth your time to step back and assess your response and see what is the correct response that you wish to give. So there are many, many types of implicit biases. There's an affinity bias. So people like people who are either look like them, have the same background as them, went to the same school as them. You'll see a lot of this in panels where everybody trained at the same center. There's an attribution bias. So if somebody says to you, this thing happened to me and this thing happened to me, and I believe it was a form of implicit or unconscious bias, because you have never experienced such a thing, you don't take their experience seriously. And that unfortunately happens with great regularity. There's a beauty bias, so people who are more beautiful, more tall, more slender, more handsome are viewed more favorably. There's a confirmation bias, so if you initially love this person, maybe they're a very tall, good-looking person, and they spoke well, and they had a nice suit on, you don't wish in the future to take into account any negative attribute that is ascribed to that person. There's a conformity bias which is sort of like being sheep, where the whole group likes this guy, so I better like this guy, or most of the group likes this woman, so I better like this woman, rather than holding back and exercising your own judgment. Same thing the other way. The whole group does not like this person. The whole group or most of the group thinks they're a terrible surgeon. I'm also going to think that without evidence of it. Gender bias is very important, as is racial and ethnic bias. And then there's something called a halo bias and a horns bias, which is somebody either is considered a saint or a sinner and can never move off of that pedestal or that understanding by you. So men are overall 1.5 times more likely to be hired for any job than a woman. 58% of workers notice the beginnings of ageism when they enter their 50s. There's a name bias. So if you happen to have a white or Caucasian sounding name, you're going to get a call back once they've perused your CV or your resume, 50% more than an African American name. And Asians are 28% less likely, if they have an Asian name, to get a call back compared to a white name. And of course, there's a height bias, as we discussed. So I'm going to give you a couple of vignettes and see what you think. The first time I gave this talk, actually, a version of this talk was at University of Pennsylvania this summer. And I gave it because my friend Michael Ruckenstein, who's one of the professors there, called me and said he couldn't believe it, that his young intern had told him this story and he just couldn't believe this happened. And once I stopped laughing and I said, really, Michael, you've never experienced this? I was so grateful to him. This is a form of true allyship where you really pay attention to what somebody is saying about something you have never experienced and do something about it. So a young Black woman intern was waiting for the rest of her service on a floor to start doing the morning rounds, and a floor nurse came by to ask her if she was transport. Now, this woman, this is a stock photo, but she looked quite presentable. She was wearing scrubs, she was wearing a hospital ID. Think about your own implicit bias. This young woman in this picture happens to have very natural African American hair. And there's a whole Twitter thread about how natural African women and African men are allowed to be. Would you consider her more of a doctor if she had pulled her hair back like this, if she looked a little less ethnic? You have to think about that. This story happened to me, and I did not look like this young, beautiful doctor in the picture when it happened, but that's the picture I found. This was a few years ago. I was in the intensive care unit at 6:30 in the morning, checking in on my patient on whom I had just performed a suboccipital resection of an acoustic tumor. The day before, the patient and I were talking. I have a very nice relationship with a majority of my patients, so we may have been looking like this, sort of smiley and happy. A young man entered and just broke into the conversation. No, excuse me, no this, no that, just started talking above me and started talking to the patient, who was quite taken aback, and as was I. So I asked the guy what he was doing. He said, well, I'm the physician assistant on the service. And I said, well, I'm the surgeon on the service. And he just didn't know what to do. And I said, why would you interrupt like that? Oh, I thought you were a family member, he said. Not that many family members are there at 6:30 in the morning with an ID badge and a white coat. But I said, but even if I were a family member, why would you interrupt? Why? So there's a few levels here. And this patient, post-op, hour 14 or something after his acoustic tumor, he remembers that incident to a T. So be aware that patients are watching us all the time. This also happened to me. I was operating with a young female resident, and behind the curtain, the male anesthesia attending suddenly started advising the female anesthesia resident about that she should go into pain management because she's going to have babies one day, and that's really better for a mom. And she was not a mom, and she had not, in fact, asked him about anything to do with careers for women. And we're working, and the patient, of course, comes first, so you pay attention to what you're doing. And then my resident and I were sort of talking about this over lunch in between cases, and one of the senior anesthesia leaders came by, happened to be at our table, and I was new at the hospital at this time, so I didn't really know all the players. And she overheard us talking, and she said, oh, general surgery, no, she said, oh, surgical attendings are so disrespectful of women. And I said to her, well, I'm sorry to say this was actually an anesthesia attending who did this. So there are so many levels of bias here, and all of these have to be addressed in order to move us forward. So what happens at the podium? Well, there's gender bias at the podium and everywhere, frankly. If a woman introduces the speaker, whether they are the same or opposite gender, almost 100% of the time, the first introduction, like Paula's of mine, would be by doctor and the name. And then subsequently, I might say Miss Coyle or Dr. Coyle, and then subsequently say Paula. But basically, we treat everybody, give them that first level of respect when we introduce them. When a man is introducing a man speaker at Grand Rounds, he will use the term doctor and the name about 70 to 75% of the time. But if he is introducing a woman speaker who is given who has ascended to being able to give a Grand Rounds, he is going to use an honorific less than 50% of the time. And this is a significant difference. And you can actually change that to anything. So you can see the way young trainees are introduced as Mr. or Dr. something if they're a man, and first name if they're a woman. And this happens repeatedly. And what it does is, in a very subliminal way, it undermines the confidence that the patient has in that person and that the person has in themselves. And it implies that there's no confidence that the senior person has in the junior person. They may not mean it, but that's what it implies. So what is a manel? So in 2019, Francis Collins, who's the director of the National Institutes of Health in the United States, wrote an earth-shattering paper called Time to End the Manel Tradition. And he said, it is time to end in science of all male speaking panels, which are shortened to manels. And too often women and underrepresented minorities, which you call BAME, BAME, are conspicuously missing at marquee speaking slots. So he said, if he gets a speaking invitation where scientists of all backgrounds are not included, he will decline to take part. And that is really a profound statement coming from an extremely well-respected leader throughout medicine. So I'm going to go back a couple of years before Dr. Collins. In 2017, at the American Neuro-Otologic Society, it was the year that I was finishing my past president year of the American Academy of Otolaryngology. I was at the meeting, and there was literally an 8-man manel talking about something. And I looked at this manel, and there were 3 or 4 men who absolutely belonged there. They had really done amazing research in the area or amazing clinical work in the area. But the other 4 or 5 people could have been anyone. And I looked around the room, 400 people in the room. I could easily pick out 15 or 20 women who could have taken those spots. And I thought about it, and I have to tell you all that from the beginning of time, which for me, the beginning of time was about 1988, 1989, when I was a trainee in ENT. From the beginning, I have written down on my evaluations, where are the women? Why are there no women at the podium? Where are the women? And I've been writing this now for 30 years, right? By the time 2017 came around. So I stood up at the end at the microphone and I said, I want to congratulate you on an excellent manel. A manel is a men's only panel, and it is disrespectful of the leadership of our society to disregard the diversity in our membership. And if I tell you that the silence was like the silence before a sonic boom, it was that silent. And then there was a huge round of applause because people saw, and people don't want this to happen. But until you point something out, it's not going to change. And what happened was I was invited to write a editorial, which got published in the Otology and Neurotology Journal, and then got republished in Clinics this August 2020, the tinnitus issue, on diversity in our societies. And if you just look very briefly, the dark black is men, and you can see that of 25 American Otological Society meetings, the guest of honor was a man 24 times and a woman twice. One of the women co-presented with the male guest of honor. And if you look at the lower slide, which is hard to see, you can see that there are a few women who are allowed to present non-surgical topics like tinnitus and dizziness, but in fact were really not invited to present on surgical topics. And that's really a subconscious bias that hurts careers. We also get bias from patients. So patients will unfortunately ask for or demand a white doctor or a non-Muslim doctor or a male doctor. Often when the woman or the minority physician is finished explaining something to the patient will say, oh, I'm waiting for the real doctor to come. If I've plenty of times entered a patient room with a junior trainee who happens to be a man and often is significantly taller than I am, and the patient looks directly at them, even though I'm the physician giving the advice. So WebMD and Medscape surveyed 822 US physicians, and 60% had heard offensive remarks from patients about a personal characteristic, either their youthfulness, their gender, their race, or their ethnicity. As a result, about half of those had the patient request a different doctor, which is so many words, but I'm going to say the word ridiculous. Primarily targeted are African American people and Asian American people and women physicians. And even 12% of physicians endured offensive remarks about their weight. I was actually doing a myringotomy on a patient. I thought I looked really pretty that day. I had a pretty dress on, and my back was arched a little bit under the microscope. I hadn't really studied my ergonomics very well. And the husband, and as I'm bringing the knife into the patient's ear, the husband over there says to me, "Oh, so when are you due?" And I pulled out because I didn't know what he was saying to me. And I said, "Excuse me, when are you due?" I said, "Oh, my baby is 4 years old or 5 years old." And I just continued. And as I'm entering, he again says, "Oh, your house must be very messy." And again, I pulled out because I thought, I don't know what's happening here. And I really want to focus on the wife, obviously. And he said, I said, "Excuse me." And the wife is, turning beet red. And the husband says, "Well, look at your stomach. Clearly, you don't lean over and pick up any of your children's toys." And he felt that that was kind of an appropriate thing to say to somebody who was about to stab his wife. I said, "Well, yes, thank you, sir. I just needed to be quiet while I do this procedure on your wife." And I proceeded. And I put in this picture because we've just recently, Emma and I have had a dialogue on Twitter about how we miss the fact that we were young once and hoping for wrinkles and gray hair. So there are macro and microaggressions. And macroaggressions are when you're just racist to everybody in that race, or gender biased to everybody in that gender, and it's sort of a global phenomenon. Microaggressions are real or perceived everyday verbal, non-verbal, or environmental slights or snubs, insults, and they are really directed in this very cutting and subtle way to the marginalized person. I have to say, I think British people are really, really good at microaggressions. I think you guys have a great vocabulary, unfortunately, for microaggressions. But the microaggressions are something like, well, you don't seem gay, as if gay seems in a certain way or gay seems in a negative way. Or often people say to me, "Where are you from?" And I'll say, "Oh, but where are you really from? Where are you really from? Because you are not one of us. You can't be American if you look like that and that's your voice and that's your face." Women are often told you should smile more, you should be more pleasant, you should be more this. And I'm like, okay. I have been asked several times along the course of my career, I've been told, "Oh, you speak English really well." And my response to that is, "Oh, that's funny because I'm from the Lower East Side of Manhattan where we don't speak English very well." And then a lot of, "Oh, I mostly don't like Black people, but you're different. You're unlike the rest of them." These are all terrible microaggressions that really cut down on somebody's self-esteem very clearly, even though their name is micro. So allyship is, if you are not in that group, or you're not that person, and you either see it happening, hear it happening, or hear of it happening, please do something to make it stop. Otherwise, these people die by 1,000 paper cuts. So Julie Freischlag, who is a surgical leader, and all of these people are amazing people to follow on Twitter. They have some incredible posts on Twitter. She gave a microaggression masterclass at the Association for Women Surgeons last year. And we wish these comments didn't occur, but they do. So you have to be prepared. You can't disappear when they say something stupid like, "Well, you're gay? You don't look gay." Well, that's a dumb question or a dumb statement. having to be constantly, on guard and prove that you belong erodes away your self-confidence. So you need to take charge against people who may derail you. Obviously, having more people who look different from each other and are different from each other in leadership is the most important. But you can ask a direct question. I don't look gay? What does that mean? What does a gay person look like? I was told at a party when I was like 16 or 17, oh, you're South Indian? You're not fat and ugly and dark. And I'm like, oh, that's not my experience of what South Indians look like. And I asked directly, assume good intent. I'm sure you didn't mean to insult me by saying that, but it didn't feel good. Call someone in. So when I heard that anesthesiologist say that to his trainee, I really should have, at the conclusion of the case, said, hey, Dan, do you mind if I talk to you a little bit for a second? I was a little uncomfortable by you doing that, and I don't think you meant to hurt her, but this may have hurt her. Call someone out if they're being egregious. Just call it out in front of everybody. That is not cool, is fine to say. And then you can say, I don't feel good about what's happening here. You are picking on every Black person in this group. You are picking on every man in this group. You are picking on every short person in this group. I don't like it. Can you please stop? So what is imposter syndrome? So an imposter syndrome is a fear of being publicly exposed as a fraud in a stress-related disorder. So this is you, everyone sees this beautiful, accomplished, smart woman, and when you look in a mirror, you see a hot mess. Or you walk along and you don't realize everyone else feels the same way. Everyone seems to know what's going on but me. So Maya Angelou, incredible poet and author, says the real difficulty is to overcome how you think about yourself. And absolutely in training, we start feeling really like imposters and we grow up feeling a little less like imposters. But it's very important that you keep examining and improving that which needs to be improved and ignoring sort of the negative self-talk. So does implicit or unconscious bias actually do any harm? Yeah, unfortunately it does. This article made me cry. 1.8 million sequential hospital birth records in Florida, in the great state of Florida, were looked at between 1992 and 2015. So these were not cherry-picked. Every single birth was looked at. Black babies, newborns, were 3 times more likely to die in the hospital than white newborns when they were cared for by white doctors. When Black doctors cared for Black babies, that mortality rate was cut in half. The race of the doctor caring for the white baby did not matter. And there was no correlation between maternal mortality, because we do have a higher rate of Black maternal morbidity and mortality, unfortunately. But that was not the correlation between that and the race of the doctor. So the difference is attributed to racial concordance between a grown person and a newborn baby. And that nearly broke my heart when I saw that. And if that's happening, we need to stop that immediately. Can implicit bias do some good? Yeah, it actually can do some good because representation matters. So in a large survey of 1,300 Black men in California, they looked at what was the difference in preventative care when they were assigned either to a Black doctor or a white doctor. So Black men with a Black doctor were more likely to opt for the preventative tests that would help them live a healthier life than if they had a non-Black doctor, including diabetes screening, cholesterol screening. And they were also, if they had the same concordant doctor, more likely to discuss other health problems and share personal information with the doctor, which all goes to better health outcomes. So let's talk about hysteria. So the word hysteria derives from hysteris, which is our uterus. We have been called hysterical from time immemorial. There is, in fact, pervasive implicit sex and gender bias in medicine that leads women to be misdiagnosed, neglected, dismissed as complainers, accused of being anxious, depressed, told their symptoms are all in their heads. Any dizzy patient you've seen who is a woman has been told by at least one, if not 5 or 10 physicians that she's not happy in her marriage or she doesn't like her children or whatever. And I'm like, well, you don't have to be happy in your marriage or like your children, but I have to take care of your dizziness. And I think that's really important. So heart attacks are the #1 cause of death in women, which most people don't know. Only 22% of primary care physicians and only 42% of cardiologists feel prepared to assess risk in women because women don't present with that crushing chest pain and left arm pain and diaphoresis that the men present with. They present with indigestion, they present with back pain, they present with feeling tired. The symptoms are much more subtle in women. The survival rates for women with acute heart attacks are 2 to 3 times higher if their doctor is a woman, and a little bit better if the male doctor has actually treated women patients and or worked with women doctors. It's 8 minutes longer to get from the emergency room to the angiography suite to get your balloon catheterization if you're a woman than a man. If you have knee issues, 60% of men and only 15% of women are counseled about surgery to help your pain so that you can resume normal life. Acute abdominal pain, women wait much longer for pain medication in the emergency room than do men. And 40% of women with serious autoimmune disease have been told that they are hypochondriacal or hysterical by many, many physicians before they finally get around to a diagnosis and treatment. So I'm not making it up, right? So there's actual data. Women physicians, there are some really interesting studies that show that we have better outcomes, fewer readmissions, patients do better under our care. But when we look at these Press-Ganey scores, which are the way that we are evaluated by patients, about women gynecologists are 47% less likely to receive top patient satisfaction scores from women patients, despite providing the same or better level care. So let's talk about some of the things we take care of. We take care of dizziness all the time. So this is from Medium, a woman named Laura Elliott wrote down, she was 25 years old, she was sitting in the hospital, waiting to see an ENT consultant. Her neurologist had referred her and she'd been waiting 5 months for this appointment. It had been 1 year and 7 months since her whiplash injury, and then she had some chiropractic correction, which made it worse. She's got chronic dizziness and vertigo. Her hearing was normal. The consultant came in and said to her, well, there are a lot of hills in Sheffield. There are, in fact, a lot of hills in Sheffield. But this is like you're unhappy in your marriage, you don't like your kids, you don't like whatever. She has a real dizziness, and frankly, I can pretty much guess what is going on with her. But this is somebody in whom her non-concrete, not easily identifiable, no hearing loss, no broken bone, was diagnosed as hysteria rather than as the true problem that is derailing a 25-year-old from normal life. This paper made me slightly crazy. This was published in 2012 and looked at gender differences in dizziness. And it starts as biased as it possibly could be. Contrary to our expectations that women with vertigo, dizziness, and unsteadiness suffer more from self-perceived disability, anxiety and depression, men actually suffer more. So they started by saying, well, we all know women complain so much, let's do a study to show it. And they were unable to show it. What about cancer? Well, you would think that cancer is cancer and you take care of it. Unfortunately, we see huge racial disparities in outcomes of head and neck squamous cell carcinoma. The overall survival for white Americans is 3.7 years. The overall survival for African Americans is 2 years, so about half. And in the oropharynx, it's really half. It's 1.9 versus 3.8 years. Every tumor presented at the same stage, same type of disease, same treatment, other except for oral cavity squamous cell carcinoma, where African Americans presented with more advanced disease. But despite all of the similarities in presentation, treatment, comorbidities, age, gender, African Americans in the red did significantly worse for overall survival than did the US born and white people. So why is the oral cavity different? Because white people have more HPV positive oral cavity cancers than do Black people. So if you look at the graph on the right, the blue is white people who are HPV positive. They do significantly better than white people who are HPV negative, who do as badly as Black people who are HPV negative. What about cochlear implantation? The criteria are very concrete and we know who needs it. And unfortunately, we see lots and lots of discrepancy in who gets this very needed intervention. So if we start from the left, women meet the criteria more often than men, but get the implant a little bit less than do men. White people meet the criteria much less often, but get the implant much more often than non-white people. We divide white people into Hispanic and non-Hispanic in the United States. So non-Hispanic white people and Hispanic white people meet the same criteria about the same percentage of times, but the Hispanic people get the implant much less. If you don't speak English and you don't speak it fluently, you get the implant way less than English speakers. Single people and widowed people get the implant less than married people. And even though private insurance people meet the criteria more often, government and private insurance get it at about the same level. Another set of statistics I could have looked at that I did not was to look at multiply handicapped children. They are not the easy slam dunk cochlear implants of the non-handicapped children. And they, even though they meet criteria, they are unfortunately often not granted implantation because their good outcomes are much less than other children's good outcomes. They actually bring down the outcomes of the implant center, which is really very unfortunate. So what about COVID-19? Well, we have shown striking racial disparities in COVID-19, where we see huge increases in hospitalizations and death rates if you are Black, Hispanic, and even Asian compared to white. And this year has unearthed a lot of racial disparities in our country and in our world. But we may see significant adoption issues. So 71% of Black adults in this country, 61% of Hispanic adults, and only 41% of white adults know somebody who has been really sick or died with COVID, not just positive, but really sick or died. Unfortunately, the inclination to get vaccinated is exactly the opposite, with only 42% of Black adults saying that they are planning to get vaccinated. So how did Black people learn not to trust? And this is a really good article that appeared, I think 3 days ago in the New York Times by Charles Blow. He's a really interesting author to follow as well. So we have done very poorly by our Black community. We enslaved them for 400 years. J.M. Sims, who is considered the father of gynecology, actually did absolutely barbaric operative experiments on women slaves to correct vesicovaginal fistulas without anesthesia and without proper consent. And once he was successful, white women flocked to him for care, but not a single one could tolerate anything without anesthesia. So our society had a belief that Black people somehow do not feel pain the way white people feel. We also considered Black people either not human or 3/5 of a human for a long time. These hurts continue for far longer than the laws change. Our Civil War to free the slaves was fought from 1861 to 1865, but the freed Black people could not access health care because people refused to take care of them, physicians and doctors and hospitals, and nobody wanted to take responsibility for paying for that care. So we lost at least 25% of former slaves to illness or death in the years immediately around and following the Civil War. In freedom, it was not so free. There was a lot of forced sterilization. 65% of the 7,600 plus sterilizations ordered by North Carolina, so these were ordered in jail systems and mental asylums, etc., they were done on Black women. There was something called a Mississippi appendectomy. 6 out of every 10 women who appeared into a hospital for any reason in Mississippi ended up with either a hysterectomy or tubal ligation. And so this was, just without their consent. And then we have the infamous Tuskegee syphilis experiment. It started as a 6-month experiment in 1932 and lasted for 40 years. They looked at 400 Black men with syphilis who were deliberately left untreated so that doctors could study the disease. And they were injected essentially with saline as opposed to with penicillin. And that was only halted in 1972, so not so long ago. We have also, unfortunately, profiteered off of Black people. If you have not read this book by Rebecca Skloot, you absolutely should, and you should read the reason why she became interested in this. The backstory is as interesting as the book. So the HeLa cell line is the cell line from which we have derived many, many, many chemotherapeutic agents. And it's named HeLa because it came from a Black woman named Henrietta Lacks, who was treated at Johns Hopkins Hospital. Neither she nor her family gave consent for her cells to be used, nor have they been compensated. And as you know, chemotherapy is a multi-bazillion-dollar business throughout the world. So where are we in otolaryngology? Oh, I'm going to go as fast as I can. We're about half the population. We earn a lot of the degrees. If you look at the ethnicity, you can see it listed on the left. In ENT, we have gone from 11% to 17% overall, with trainees making up about 40% now overall. We're an aging population, so we really need to replace us with young people who look more like our society. Whites have stayed the same, and everybody else has dropped in this 10-year time period. So is it a glass ceiling? Is it a glass labyrinth? You can see the man at the top saying glass ceiling. I don't see any glass ceiling because she's under the glass ceiling and they can't see it. Finally in the United States, we broke our glass ceiling at the executive by electing as vice president-elect the first woman in the history of our republic. So, you guys did it well before us. India did it. Israel did it. Ireland did it. Everybody did it but us. So we finally did it. The concept of the glass labyrinth is the woman is there and she can't see the barriers. So she thinks it's a straight path, but it's actually a windy path that she has to learn how to take. And we see this in the underrepresentation of women in leadership positions. So women are entering medicine, about 50% of medical school classes, but only 35% are practicing. Nearly all of us experience gender discrimination. Black people are leaving and women are leaving. And this is truly a crisis. So why do they leave? They leave because of disrespect. They leave because they don't get paid enough, and that's a real problem. They leave because they are sometimes the only person there and they feel like the outsider or the imposter. And they leave because we really don't have good family care or child care for especially women who are juggling home and work as opposed to men who are usually not. So there's overt and unconscious bias. And To Serve with Love, it was overt bias of this very well-educated, debonair, high-performing Black teacher in a poor white neighborhood. In My Fair Lady, You know, the same woman, when she said, "Oh, governor, buy a flower for girl," was treated poorly when she said, "In Hartford, Hereford, and Hampshire, hurricanes hardly happen." She was treated just fine. And then the joke in the middle, I find it appalling that people still don't understand that the doctor is the surgeon, is the mother. So we have huge underrepresentation in faculty and trainees in otolaryngology, and without the faculty, the trainees feel unwelcome. And once we even get them in, unfortunately, that implicit bias causes Black and Hispanic people to be dismissed by programs much more frequently than white people. And that's a real issue. So lots and lots of people experience implicit bias, both as patients and as healthcare professionals. And I think it's really incumbent upon us to make sure that we keep this in our minds as we go about our day. So diversity brings better patient care and better outcomes, whether you're looking in hospitals or in businesses. People just make more money if there are diverse teams running even financial sectors. So you can take your own concrete steps. Project Implicit is at Harvard, and you should take this quiz yourself to see your own implicit biases and what you can do to improve that. This is a fantastic video made by Ellen Friedman and her colleagues at Baylor College of Medicine called The Threads Among Us. Just watch it, and there's actually an educational piece that goes with it. So what can you do? Number one, be conscious of your own implicit bias. Recognize micro and macroaggressions and don't discount it when other people experience them. Be an ally. So for that anesthesiologist, I really should have taken him aside and said something, and I wish I had. Don't participate if you're invited to a men's only or a whites only paper or panel. And remember that diversity is not just to make everybody feel good, it actually confers distinct outcome advantages.
I had two questions. Obviously, I've experienced lots of these things being a woman, but I appreciate that I am probably naive to lots of other biases. As a group in ENT, as Wentz, we've got a Manel sort of thing that we send out, a statement that basically says ENT UK supports us in not having manuals, but we find that we get quite a lot of a few things that people say every time we approach a manual and say, you know, we try and do it very politically correct, but we get people saying, women saying, I don't want to be the token woman because I'm just there for tokenism, and also just like as you said, it's generally the same. Once you get to the high up levels, same men that gets asked and asked again, and it's the same women that get asked and asked again. And we know that statistically, although I can't talk for individuals, women are more likely to do care, so childcare or elderly parent care, more household duties, etc. So they don't necessarily have the same time to give to the panels. And so if they say no, then the man will say, oh, we asked a woman and she said no. And I don't know, A, how we can get more women to be happy to be the token person until we get ingrained, and how we can expand those manuals' view into more females who could talk, basically, or any other sort of minority.
It's an outstanding question. So number one, if you are asked as the token, say yes and be the best token ever. The way to win is to win. So if you are the token woman on a panel, just be the best person on the panel. It's kind of easy. You know, women do have childcare, elderly care, this care, that care. And still in 2020, during COVID, when everybody was giving these talks from home or from their office, we still weren't invited. So this, oh, she doesn't want to travel, she has small children, that's all hogwash, because we still weren't invited and the panels were being delivered from our home. So I don't think it's impossible for a woman to close the door for an hour in order to participate in science. We actually made a rule at the American Otological Society, the American Neurological Society, the American Rhinological Society, and several others, that we would not permit the fielding of manels again. And in fact, we were, the AOS, the American Otolaryngology Society, was asked to sign off on a paper that had several authors on it, none of whom were a woman. It was a surgical paper with no women surgeons and a couple of token women audiologists. And we said, nope, this does not meet the rules set by us, so we will not give our imprimatur, we will not give our approval for this. If you can't, for whatever reason, you cannot make a speaking engagement that you are invited to, say, you know what, I unfortunately cannot make that, but Paula over here can make it, and she is really excellent. And I actually did this last year, and it was really interesting. I just couldn't go to something, and I put up somebody that I thought was terrific, and one of her male colleagues called me and said, oh, she doesn't do that. You know, she's not good at that. And I said, why wouldn't she be good at that? If I'm good at that, she's good at that, because we're just otologists, like that's what we do. And I called her and I said, hey, you said yes, but are you comfortable doing this? Because I didn't want her to feel out of an obligation. And of course she does that. And of course she's good at that. And he's a very nice man, this man who spoke to me. So I don't think this was deliberate on his part. I think this is, again, an unconscious or an implicit bias. And I think until we fight it tooth and nail, we will not overcome it. You will see that when women organize panels, not only are there women and men on the panel, but they're in fact underrepresented minorities on those panels and on those papers at a much higher rate than unfortunately when a white man does it. For the clinics, I actually, as consulting editor, I will, I've had 50% of my guest editors as women. I've had a significant percentage, but small, of underrepresented minority, because we just don't have so many to pick from who are senior enough in the United States. But when they send me an author's list or for the articles, I will send it back until it meets my criteria for diversity. And I think being unafraid to be open about that is very important. Dr. Brackman, Daryl Brackman, was moderating a panel in 2018. So the spring after my big statement at the September 2017 meeting. And he called it a femanel because he had 3 women speakers and he was the moderator. That was the best panel by far of that meeting. So just say yes and then do the best. And if you for some reason cannot, or you have an opportunity to invite somebody else, invite somebody, I'm going to say, atypical.
Okay.